We are live on Restream. Let me hop over to Facebook just to confirm. I think we should have plenty of people waiting for us there. I'll let them know about the time change today, so they've probably been waiting anxiously. Aha, we are there. We are indeed broadcasting there, and people ready and waiting and joining the room already, so let's not keep them waiting any longer. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week, or this month, and every month. And I am a filmmaker and a writer, among a few other things. And I've been working with CCF for over 10 years now to create all kinds of video content, live video series like the one you'll watch today, patient-centric documentaries, dense treatment-based videos, conference videos, social media videos, all kinds of videos in that decade plus, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, this show specifically, the value, as I see it, is very much twofold. One, the information and hopefully answers to your questions that you'll get from our guest presenters. And two, the shared stories, shared experiences, and support from within the community. The overall net community, and the community that we've cultivated here at Luncheon with the Experts. I say this every episode. It is so profound. It is I'm very appreciative and grateful to be at least tangentially a part of it. It is one of the most supportive communities I've ever seen. And so I say all that to say, if you're new to this journey, if you're new to the show, introduce yourself. You'll see people in the comments doing that. Embrace this community. They will embrace you back, and that is a big part of the journey in terms of having success, whatever that looks like for you, is leaning on those other zebras, if you will, in the net community. I highly encourage you to reach out. We see people from all over the world already chiming in. Canada always shows up in big numbers, and we see people. That's one of my favorite things about the show, is to see how far each program, even live, reaches to all corners of the earth. So reach out, say hello. And in the meantime, a few announcements before we get going. First and foremost, we always want to thank our sponsor, Ipsen Biopharmaceuticals, for their support of the series. We couldn't do the show without them. And we do have this disclaimer from them. That is, that the opinions expressed by the guest presenters today, and as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't necessarily endorse or promote any of the views, opinions, or information provided in today's presentation. So, audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, as always, that's a lot of words, as disclaimers tend to be. That last line is really the takeaway I want you to focus on. We don't know your specific case. One thing I have learned, being a part of this community, is that each case of this disease is unique, and therefore each plan and path forward is as well. So take some of this general advice and answers to your question that you received today back to your home team, which does know your specific case, and make the best plan for you moving forward. Okay, all that said, I am very excited to welcome to the show, for the first time, I might add, Dr. Vineeth Sukrithan. Dr. Sukrithan, welcome.
Thank you so much for the invite, and it's such a pleasure and privilege to connect with all of you.
Absolutely. Well, sir, your reputation precedes you. But for those who might not be familiar with you or your work or the role that you fill in this neuroendocrine tumor community I've alluded to, tell us a little bit about more about what you do, where you work, and how you became a part of this community.
Yeah, absolutely. So, once again, my name is Vineeth Sukrithan. I'm an assistant professor of medicine here at the Ohio State University, a comprehensive cancer center in Columbus, Ohio. I specialize in, as we all aware, neuroendocrine tumors, but I also do thyroid and adrenal cancer. So we call it the endocrine cancer program here. In terms of my background, so I'm a medical oncologist, and I finished my training in medical oncology in 2020. And I had the good opportunity and the good luck to actually do some lab work while I was a fellow at the Albert Einstein College of Medicine in New York. And I fell upon a lab that really did a lot of neuroendocrine work, specifically neuroendocrine lung cancers, such as small cell lung cancer. And I think it really drew me to the field, and I came to realize that there's a lot of work to be done in the neuroendocrine field. It's fairly small, but there's a lot of exciting discoveries and opportunities and possibilities. So when I looked across the U.S. for a job, the Ohio State University really stood out because we have a long history of having expertise in neuroendocrine tumors here. So Drs. Orange and Ellison, one of the first surgeons and doctors who first described gastrinomas, that was at Columbus in Ohio State. And leading on to the 90s, we had Dr. O'Dorozio as well here, and he recruited Dr. Manisha Shah, who's carried forward the legacy. And I hope to do the same. So I'm a clinical trialist, but my focus is on really like translational studies, including genomics, specifically with a focus on immunotherapy in neuroendocrine tumors, and understanding what the barriers and the challenges are and how we can overcome them together. So thank you for the opportunity.
Absolutely. It does sound like you have some big shoes to fill with some of the names that you've mentioned in the community, but it seems like you're well on your way because an announcement that Dr. Sukrithan didn't include was that just a couple of weeks ago, you won the Best Poster Presentation Award in Basic Science at the NANET Symposium. So congratulations for that.
Thank you.
Absolutely. I'm always very interested in one's path to this disease. What are if I could use the word intrigues, what are the parts about this disease that draws you to it? It is usually something that intrigues someone, whether it's an unsolved problem they seek to solve, or what attracted you, for
Yeah.
lack of a better word, to this field?
I think one of the challenges really is the terminologies that we use. And as you know, like there's still some doctors, who would say that, oh, it's only a carcinoid. We think that's a benign disease. And as you can imagine, that drives me wild. But
Right.
so there's a lot of opportunity for really understanding the disease biology and explaining the differences between a low grade, well differentiated tumor and high grade, poorly differentiated one. I mean, the difference is just so large, and I feel that it's a challenge and both an opportunity because we're dealing with, thankfully, in some situations, a somewhat slower growing disease process, but sometimes it can also be fairly fast moving. So I think that's one of the challenges that drew to me the fact that this one disease can really span such a wide spectrum. And why is that? And I think there's also a lot of disease biology that we are yet to understand fully about why is it that sometimes the ki is low. Does it seem to change over time in some cases? What do we do about that? How do we kind of relate that to newer things like PRRT, SSTR2 expression, and also like fairly newer concepts like the efficacy or the lack thereof of immunotherapy. So there's a lot to understand just in terms of like the heterogeneity in how this disease presents, as well as what we can do for folks unfortunately with the disease. So I think it makes it uniquely challenging. It's a challenge that I think let's say doctors who don't specialize in this tumor are not particularly aware about. And breast cancer is fairly well described, or colon cancer or lung cancer. But when we come to neuroendocrine tumors, the fact that it can happen anywhere and that it has such a wide heterogeneous presentation, I think it really speaks to the fact that you need to be seen at a fairly large center where we have experience with dealing with these tumors, because otherwise sometimes you do end up getting information that's not unfortunately valid for your type of disease.
Got it. Thank you. Folks, before we move forward, we always want to send a special shout out and love to our partners, LACNets. We recently merged together to continue offering support to the neuroendocrine tumor community. You can reach out to us if you have follow-up questions after today's episode at carcinoid.org or at the support line directly at lacnets.org/support line. Their support line offers guidance, resources, referrals to NET patients, or referrals for NET patients, their loved ones, etc. So please lean on that. In the meantime, when you're here, go ahead and start sending in your questions. Try to keep them short in general if you can. And if you stay on the line, we may ask you for clarification on certain things. But again, just a reminder, try not to be too case specific. I know that everyone is seeking help. There is no limit to how many questions you can ask, so try to ask them in little chunks. In terms of the people in the audience already, I would be remiss if I didn't send a special shout out to all the North Carolinians who seem to be in the audience today. I am also in North Carolina, so it's special to me. And S from Belize, welcome. And there's even one Go Buckeyes, Dr. Sukrithan. So that I believe
Yeah,
is
I saw
directed
that
towards you. um,
immediately.
you saw that immediately, I guess. I always love how Ohio State makes sure to say the Ohio State University. You see it on Saturdays in the football games when the defensive line announces their names. Okay, so we got some questions already coming in. Our first one comes from Gene, one of those North Carolinians. What do you know about Cabometyx, or that's the brand name for cabozantinib,
Yeah.
in use for neuroendocrine tumors?
Yeah, very exciting. Thanks for the question. So, we've been using medications that target the tumor's ability to grow blood vessels for a long time. So, sunitinib or Sutent, as you may be aware, is one of those treatments. It's been around for a while now. It's an approved treatment for pancreatic neuroendocrine tumors. So we know that this is a pathway that's really worth targeting in neuroendocrine tumors because it does slow down the tumor, shrink it down, and improve survival. So I think there's been a while in which we tried a few different agents like pazopanib, lenvatinib, I believe axitinib as well. But finally, we just completed a trial of cabozantinib, which was, as you may be aware, after an interim efficacy analysis was done, the data looked really promising. So we should have information soon from Dr. Chan's presentation at ESMO, which is coming right up. So I think we'll know more then. But I think it seems promising. We had probably close to 20 patients or so on the study at our center. So and quite a few of them did do better than we would have expected. So I hope, and for the community as a large, that we can kind of build on this progress,
Mm-hmm.
because this group of medications that target the blood vessels has a role to play. And I'm glad that we are finally progressing beyond the Sutent era, which is one of the first agents that showed that it was effective, but it has since been surpassed by some of the agents that I mentioned in, for example, in kidney cancers, where they have three or four approvals in this space. So it's great that we might have access to something newer, more exciting fairly soon. So yeah, I think we'll have to wait for some of the finalized data and to see exactly how effective it is. But everything from based on experience, I think it looks really promising.
Got it. Thank you. And thanks for your question. Next question comes from Reese. Reese says primary tumor is on the tail of the pancreas with many tumors in the liver. How important is it to get the primary removed, or should the main focus at this point just be on the liver?
Yeah, I mean, this question comes up fairly often. I do think my personal opinion is, I think ultimately lifespan is determined by the metastasis. So I don't feel strongly about chasing the primary site, especially if we have quite a few metastases. It's obviously an individualized decision that I'd encourage people to have with a multidisciplinary team at your institution, including your oncologist, your surgeon, so that everyone can get together and decide on a plan that makes sense for you. It could be a case by case situation where if you have just a couple of mets and they can effectively debulk that, it might make sense to go in and maybe deal with the primary as well at that point. But if there's more than what would be customary to do debulking on, then it probably makes sense to be conservative, and removing the primary from the tail wouldn't necessarily make a difference, in my opinion. So I would encourage you to have these kind of multidisciplinary conversations when you encounter these situations.
Absolutely. Thanks, Reese, for your question. There's a question Donna has going back to Cabometyx. In what scenarios is Cabometyx used, Donna asks?
Yeah, so the study was done for folks who have had prior progression on either PRT or everolimus. So we did have folks in that situation. And the reason for that is, Cabometyx is a good medication, but it's important to understand that there are side effects with it. Specifically, quality of life side effects can be debilitating in some folks, especially at the higher doses. So it's not something that I would necessarily recommend straight off the bat for folks. You definitely want to make sure that you've seen some standard lines of therapy, and so that it makes sense to take on the risks and the hit to the quality of life. Because it doesn't make sense to do that if you're fairly early in the disease process, if you have other options that may or may not have such a hit on the quality of life or side effect profile. That being said, it's fairly manageable. It's most of the things are some things that we can tweak the dose and really improve quality of life, or supportive care can be done. But it's definitely a medication that we take with a lot of respect. But we'll have to see exactly how well people did on the study before we can really answer the question of how do we sequence these therapies, because right now I think no one really knows the answer to that.
Mhm.
So we kind of use a clinical judgment in deciding, well, oh well, some of these other therapies have slightly fewer side effects, so maybe I would consider that first. But I think it's definitely a case to case discussion.
Got it. Hey, thanks, Don. I appreciate you. Next question from Cheryl. After 3 years, my cancer returned and is now in my liver, lymph nodes, and bones. My doctors recommended PRRT. What side effects are usually experienced with Lutathera treatments?
Yeah. So the good news is PRT is quite gentle, and that's been heartening to see, because initially when it got approved in 2018 or 19 or so, it was a worry that this is a fairly new regimen of radioligand directed radiation therapy. But in our experience, what we've seen is a vast majority of people do just fine, other than mild fatigue, occasionally mild nausea that lasts maybe a week or two. You really don't see a dramatic effect on your quality of life. So I really encourage patients to consider that, because I think it's great that we have a therapy that is so well tolerated, and in terms of immediate side effects, fairly limited. But there are things that your oncologist will keep a close eye on. So they'll keep a close eye on your kidney numbers, your liver function, and blood counts, because those can actually fluctuate and spike when you're on the treatment. But that's not necessarily something that you would feel on yourself. But these are some of the side effects that were seen in the Netter-1 study as well. And then long term, it's worth having a discussion about the fact that there is a 1 to 2% risk of bone marrow toxicity. So myelodysplastic syndrome can happen in 1 to 2% of people. That being said, we don't necessarily advise against that just based on that. There's a lot of I was heartened to see at NANES this year that there's actually quite a few different groups that are looking really closely into risk of MDS and what we can do about it. Are there ways to predict it and mitigate it once it happens? So I think that's definitely a field where you're going to see a lot more data come out in the next few years. But as of today, it's something to keep in the back of our mind. Wouldn't necessarily prevent you from getting a really effective treatment, but overall, as I said, people do really quite well on these treatments. The only other caveat that I want to bring up is when there's if you have quite a lot of disease burden in the peritoneum or in the abdomen, especially if it's causing you side effects like abdominal pain, it's really worth discussing with your oncologist about risks and benefits. We do know that sometimes small bowel obstructions can happen, which can be mitigated with steroids, which has become a standard practice. But so these are the overall, I would say, the topics to really discuss with your oncologist before we get started.
Got it. Thank you. Let's see. From Nancy. Nancy says, have you heard of extreme diarrhea related to copper dotatate scan? Severe watery diarrhea started within hours of the scan, and it hasn't stopped. This was in early September. The scan was negative, but going up 30x per every 24 hours.
Wow, I mean, that sounds pretty extreme. I have heard of maybe one or two of these situations, but it's so rare that I couldn't tell you if it is really related to the scan or something else that was going on at the same time. So is it possible? It is, but it's really unlikely, especially with the fact that if it's going on for more than a few weeks. That sounds really atypical. So I would really consider ruling out other things. I'm sure you are talking with your doctor about making sure it's not an infection of some kind or something else that we're not considering. But it can happen, but the time course and the severity and the prolonged nature is really unusual.
Got it. Thank you. From Siddle, I believe. What is new in intervention radiology treatment for these kinds of tumors?
Yeah, so I think work closely with our interventional radiologists. I would say that therapy is as effective as almost anything that we offer. So we have a very close working relationship with them. We discuss cases at our weekly or biweekly tumor boards all the time. I think some of the things that I did notice that was interesting in our NANETS conference this year was there's a fair amount of interest in combining other agents with intervention radiology therapies. So there was a study about immunotherapy in combination with embolization. There was another poster about combining like the TKIs or the pills, everolimus. So I think all of this actually is the future. In addition to different approaches of radioligand therapies. So Y90 we're all aware of, but there are other studies that look at even lutetium actually given intraarterially. So I think there's a lot of excitement and there's a lot of promise in that approach. But for on a day-to-day basis, I think I would say it's really about making sure you have a multidisciplinary discussion with radiation oncology doctors and interventional radiology about Y90 and embolization. What makes the most sense in a particular situation. So that's what I would say is our day-to-day focus. But there's definitely newer things on the horizon in terms of combination therapies.
Got it. Good to hear. Thank you. Next question from Ruby, which does pop up quite a lot. Ruby says, what would cause serotonin to suddenly rise high? Is it controlled by diet?
The serotonin is produced by the gut neuroendocrine cells. So there is some evidence that precursors to serotonin, certain amino acids, can cause your serotonin levels to fluctuate. But I would say it's not really something that we track very closely in our clinic, just based on the fact that it can fluctuate. So in terms of assessing disease burden, I really go by scans, and sometimes certain chromogranin and other tumor markers can be helpful. But generally speaking, we've moved away from a very close monitoring of serotonin because I think there are better ways of keeping a track of the disease status.
Got it. Thanks, Ruby. Stephanie says, my husband was just diagnosed with a net in his cecum, but also found a mass on his heart. Is it common for a net to be on the heart?
I have seen pericardial mets once or twice. I would not say it's common. So I think it's a good idea to discuss with your doctors about whether, first of all, if it's a slow growing process, I think the beginning observation is just fine, and that's what we ended up doing for my patient as well. But sometimes it makes sense, if especially if it is in an area that's causing problems or either hemodynamically or electrically to the heart. It's a good idea to have a oncologist as well as a cardiologist giving you an opinion about the heart site. But it's really rare. I can, as I said, count on one hand the number of times I've seen that. But it shouldn't necessarily be, I would say, more complicated than it needs to, in the sense that as long as you have a cardiologist also giving your oncologist their opinion about what the tumor is doing in the heart, the actual treatment should be, the regimen should be fairly same to what if you had that or if you didn't.
Understood. Thank you. From CE says, are there other drugs similar to lanreotide that I can take on a quarterly basis as opposed to monthly injection schedules?
Oh, that's a tough one. I'm not that I'm aware of, unfortunately. As you know, we are trialing the oral pills. The paltusotine trial is currently ongoing. We are a site that's open. That's a daily pill, but I think it's a great idea if we, if anyone with like chemistry background can figure out a way for an even slower release SSA that lasts a quarter. Man, I mean, I think that would be even better than the option that we have today.
Yeah, I'm sure there'd be several people interested in that, from what I've heard over the years. John says, lanreotide versus octreotide, pros, cons, which one to use first or try first, and then an more interesting question, I think, why change from one to the other, perhaps?
Mhm. I personally don't have a preference between one or the other. I will say, if you look at the label for sandostatin, there is a provision or a necessity to try the subcutaneous for a week or two, and then switch patients to the long-acting LAR, which has been our practice because we want to stick to the label. Unfortunately, it's not possible for everyone, to be educated on giving themselves a subcutaneous for a couple of weeks. It is kind of cumbersome. You have to do it 2 to 3 times a day. I think one of the advantages of lanreotide is, at least per the label, that's really not something you need to do. Um, Otherwise, I think the medications are fairly comparable. Um, I've not really had any, I would say, experiences with switching from one to the other and getting any different efficacy. I think to me they are fairly comparable in terms of how well they work and side effect wise as well. All of us know that, with lanreotide and sandostatin, sometimes you do get a flare in your diarrhea for the first few days. That can be bothersome in some patients, and I have seen that slightly more often with lanreotide. But also, our preference is to give lanreotide, is based on what I mentioned about the subcutaneous. So, as long as you're aware of that, I think, and long-term side effects of things like, gallstones and certain people with constipation, I think the two agents are really come close in terms of efficacy and safety, and
Mhm.
there's not a lot that differentiates the two of them. I would also say the intramuscular versus the subcutaneous obviously is, it can be a personal preference. I have heard some folks who tell me that, the intramuscular, even though it's a longer needle, that, it feels less of a bother to their backside, which I thought was kind of interesting, because I would have assumed that the subcutaneous would be less painful. But I don't have any data to back up that one is better than the other in terms of, ease of tolerating the actual injection. But occasionally I have heard some folks with a strong personal preference, but I can't really put too much on that.
Got it. Switching gears a little bit, Jody says, how long do the results of a bland liver embolization last typically?
Yeah.
And is it true that the more painful the recovery, the better for more death, so to speak, to the tumors?
Oh, on average, I would say in our experience, a bland embolization can keep the disease at bay for a few years. I mean, it really depends on the disease biology, but on average, I think I've seen 2, 3 years, something at that time frame. It's considered a successful outcome. And if you have disease progression after 2 or 3 years, it's worth trying it once more, in my opinion. So it did work the first time. In terms of pain, post-embolization syndrome is really, in some cases, kind of mysterious. We do know that if you have a lot of tumor burden to begin with, you can have a rough time for the first week or so. Pain is, I would say, maybe 1 in 5 people has some injection site pain around the right upper quadrant that can last a week or two. But you really shouldn't have pain that is increasing in, magnitude or frequency that lasts for more than a week or two, because usually in those situations, if you are experiencing more and more pain that builds and builds, it's worth looking into. You might need to get a scan to make sure there's something else going on, either infection or bile leak or something like that. So thankfully, the pain is something that most people are okay with, and sometimes you need supportive care medications for a short period of time. But post-embolization syndrome itself, it's quite hard to predict, and it's one of my interests as well. Because sometimes I tell folks that you can predict, you can expect to feel down and out for a couple of weeks, and then I see them and they're completely fine and have no issues at all. And you see the reverse as well. So I think it's we don't know yet, like who are these folks who really have a hard time in
Hmm.
the post-stay period. And I'd love to see some like formal data on that, because right now I think it's still understudied.
Got it. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And today our guest is Dr. Vineeth Sukrithan from The Ohio State University. And speaking of that institution, Robert says, does OSU provide the new histotripsy? And could we also establish what exactly that is, Dr. Sukrithan?
I'm not familiar with that. Is it histotripsy?
Mm-hmm.
Okay. I'm unfortunately I have to admit my ignorance of what histotripsy is.
No,
So
it's like a shock wave. We have had this question once before.
okay,
Transcutaneous, non-invasive delivery of ultrasound
yeah,
energy. Yeah, okay, you got it.
yeah. No, this is unfortunately I'm not very familiar with this, so I can't speak directly to the specifics. But I will bring this up to our radiologists to see what their opinion is.
Okay.
But unfortunately, I don't have an educated opinion on that.
Yeah, understood. Thanks, Robert, for your question. And I do think I'm glad that Robert asked it because I have had this once before. So this is now the second time this is brought up. And, I'm certainly not, I'm only a little familiar with it because of the first question. So something's going on out there we might want to pay attention to. Brianna says if platelets are too low or there are other big side effects with 10 milligrams of everolimus, Afinitor, so the dose is lowered, is it just as effective or close to as effective as the higher dose?
Yeah, I have. You do see blood counts occasionally go down with everolimus. My experience, it actually does work at way lower doses as well. So 7.5, 5, all of these dose levels. I have had folks with a fair amount of disease stabilization that can last a year or so. So I don't think the 10 milligram is the only dose that works or anything. In our experience, it absolutely works at lower doses, and it makes total sense to reduce the doses once you're starting to see some of these side effects.
Got it. This next one is important. Shapiro says, I'm confused. Years ago, I had a carcinoid tumor in the appendix and was told after removal, I need no follow up care. But according to this, I am still at risk.
Yeah, so some of the guidelines regarding post-appendiceal neuroendocrine tumor, what to do is, I would say, a little bit controversial, up in the air. But in our personal experience, we do follow up for up to 10 to 15 years with scans. But some of it also depends on certain specifics, which it's hard to allude to, because it depends on what the pathologists are seeing under the microscope, whether there was neural invasion, vascular invasion, the size, your age, the pathological stage. So it's a little bit hard for me to give you specifics, but I will say that recently there is some evidence that smaller tumors without some of the aggressive features actually can have low risk of really causing problems. That being said, I think everyone will benefit from getting surveillance. Some of the controversies are really about whether they need to go ahead and get the right side of the colon taken out or not,
Mhm.
those kind of things. But overall, I think we have certain, we have fairly good guidelines about what to do after the appendix is removed. And so, even though I can't speak to specifics, I will say that surveillance is, generally what we do. It is recommended.
Got it. Thanks for your question, Shapiro. Hopefully that helped. I know that this journey can be confusing at times, so that's part of what we're trying to help solve. From Nancy, I was just given a PET scan, and my neuroendocrine tumors remain stable, not growing. But after the scan, a mass was seen in my bladder. I'm going to the hospital for another scan to see exactly what it is. Is it common after radioactive treatment to after radioactive treatments to cause other cancers? It did not light up as a net.
Hmm. I'm yet to see a second cancer that I can clearly say is like related to radioactive therapy. Um, it's a theoretical risk, but the good news is we have a lot of experience now, both in the US and in Europe now. We've not really seen a huge number of second cancers come up or anything like that. I think we would have seen it by now. That being said, it's a little bit unclear the specifics. I will say dotatate pets sometimes do light up other lesions, which may not necessarily be neuroendocrine tumors. Unfortunately, it is a good tumor, do a good scan for neuroendocrine tumors, but sometimes you do see certain areas of inflammation that do light up. So when they say that they're seeing something in the bladder area, it really depends on how hard it is on the PET scan and certain other features on the imaging. So sometimes you can see some like an inclusion cyst or something that looks like that. Occasionally, a paraganglioma or something else that can show up on a neuroendocrine tumor PET scan. But I wouldn't say that I would necessarily link any of that to previous PRRT or radiation treatments. We are yet to see any evidence of like a huge number of new cancers happen from that standpoint.
Okay, thank you, and I appreciate your question. I have had similar questions to that as well. So hopefully that helps, Nancy. Next question comes from Jane. Jane says, "My husband just finished his first round of PRRT, and he felt continuous fatigue and nausea. Any suggestions to reduce this before his next round? Nausea meds gave him too much constipation, so he's also trying to avoid that."
Yeah. Fatigue and nausea, as I said, it's the good news is it's quite rare, but when it does happen, as I can see, it can be distressing. I think supportive care is what I would do as well. Usually some of the medications that we use for nausea, as you may be aware, are things like ondansetron, prochlorperazine. If it's really severe, you can use things like Zyprexa, and occasionally dexamethasone steroids can be used. I think any one of these agents, may either by itself or in combination, should do the trick. Fatigue. The good news is I've not really, in my experience, really had a situation where I've had to like not go ahead because of fatigue with the second dose of PRT. Um, Extremely rarely we have had situations where because of decline in performance status, general lack of energy, we have reduced the doses for the second dose. But I mean, I can again count on one hand that something like that has happened. Usually the fatigue kind of peaks around 1 to 2 weeks
Mhm.
and then slowly gets better with time. And you do have a couple of months to recover between each treatment. So I would be highly surprised if you're not feeling close to yourself, like yourself, in a few weeks' time. But as I said, maybe a short course of steroids might help perk you up a little bit. But it's highly unusual that you're not able to like get more treatment based on that side effect. Usually, it's fairly self-limiting in my experience.
Got it. Thank you. Folks, we have just about 20 minutes left with Dr. Sukrithan, so keep sending those questions in. We're going to do our best to get to all of them. Inevitably, we don't because we get so many. So if you have follow-up questions or we didn't quite get to yours today, I urge you to reach out afterwards to carcinoid.org or lacnets.org/support line, as I mentioned earlier. Speaking of LACNets, they chimed in recently and gave a link and some information to the question or pertaining to the question about histotripsy, which seems to be approved by the FDA as recently as October 9th. So very, very new stuff, but there's a lot of information there. We always try to add links for things that we have mentioned in the show, so you can dive a little bit deeper into some of those resources. So next question comes from Kathy. Kathy says, is a chromogranin A of 3,400 plus concerning?
Context, right? Because chromogranin, as many of you know, unfortunately is not a very specific marker. So there are many net specialists in the field who don't even track it all that often because it can be misinterpreted a lot of the times. There are also certain labs, different labs that do it, and you get different values. And it's unfortunately we wish there was a better marker out there, but till we find something that's even more specific than chromogranin, we do use it. But I specifically advise folks not to get Kind of hung up on the number if they can. I know it's anxiety provoking to see numbers that are going up, and you want to know why. But a lot of the times, I do advise folks. In isolation, the number doesn't mean much to me. A lot of the times, there are folks who come to us with just a chromogranin number that's sky high, and I tell them, I mean, there's lots of medications and things of that nature that can interfere with your chromogranin numbers. PPI, being on antiacid, is the most common one that everyone's aware of. And I have seen numbers that are even in the thousands, even 10,000 coming from a PPI. So it's not harmful in any way, the number itself. I like to use it in adjunct with a scan. And what I mean by that is, along with the scan, if it helps me interpret the scan better. So if there is a clear disease progression on the scan, it doesn't really matter what the chromogranin says, right? Because I have visual evidence of something going on. But at the same time, if there's a scan that's really ambiguous, where it says it's a new spot, it's not really sure, they would say correlate clinically or something like that. And if there's been a consistent trend of rise in chromogranin, and if the person is also not feeling great or something new is happening, it helps me interpret the scan. So I would say it's just another tool in our armamentarium, but I wouldn't call it like an outcome that I would hang my hat on necessarily. So I encourage people to just like think of it as just it's part of their care, but the end goal is really what the scans are telling us and how you're feeling. And so I wouldn't. Some people will say we don't treat the chromogranin, right? We treat the tumor. So the chromogranin numbers are helpful in some certain situations when it's not clear what the scans are telling us, or you're waiting for a new scan to be done. But otherwise, a number in isolation is not going to harm you. It's not going to hurt you. It's all about the context.
Absolutely. Thank you very much. Hopefully that helps. Next question from Kaid, I believe. Hi, in your opinion, what should happen with a patient when they have carcinoid syndrome symptoms, repeated elevated blood serotonin, and a clear gallium?
Yeah,
What should be the next step?
it's a very hard clinical situation, and we do see these once in a while. You know, Unfortunately, it's not clear what the next best step is. I think the best thing we can do, and it is to make sure that we are doing everything we can to rule out a carcinoid tumor. So if that implies getting a dorotate PET, which we've already done, getting endoscopies upper and GI to make sure we're not missing anything out here, including like a small bowel follow through capsule endoscopy. Beyond that, I think the bigger picture is if we don't have something that's particularly worrisome on a scan or on an endoscopy procedure, the reality is it's unlikely to harm you in any substantial way long term. So I would say, the index of suspicion or worry should be lowered. All of us, we like, sometimes there are symptoms for which there may not be easy reasons that we can find on blood work. And when we do a lot of them, we'll end up with finding a chromogranin or a serotonin. Now, is that necessarily the reason for the way someone is feeling the way they feel? Hard to say. When we look for a lot of things, sometimes we find a lot of things. But I try to tell folks that if it's something that is going to be life threatening, you would have found on a scan or endoscopy. And the fact that we've not found any abnormality that looks life threatening, I would say is good news. And I know I would hope that we focus on that. But I agree that it's a really challenging situation for some folks, especially if you're having symptoms like carcinoid syndrome, which you mentioned. Without there being a clear answer, I can see how it can be really frustrating. It's also challenging to really treat, because we have agents for carcinoid disease when you have the tumor, but it's less clear cut. Like things like Zermello or some of these agents. Like how do we use these if without a proven tumor? So I really feel for these situations, and I would say focusing on the big picture is, you know, do everything you can to control the symptoms. Imodium, any other agents that make sense for your clinical context that you get approved for. But I agree that it's a real challenge for folks who don't have a diagnosis.
Definitely. Thanks, Cade or Kaid. I appreciate your question, and I believe it's the first time I've seen your name. So if this is your first time to the show, welcome. I'm glad you're here and asking questions. Julie says, I have type 3 NET in my stomach and had a total gastrectomy and 21 lymph nodes removed. NED for 9 years, no evidence of disease. Doctor wants to stop scans after 10 years. I don't feel comfortable with that since I was very fortunate that my NET was found early before it spread outside the stomach. That's
Yeah.
understandable. So the question is, should I continue my yearly scans? Is there any problem with that?
Yeah. Um, Again, context matters because I would say the size of the tumor, what they found in the pathology, how young you are when the diagnosis was made. I think that some of the challenges, the guidelines are for scans over 10 years, but we do know that there are some unlucky folks who can recur after 10, and there's no real guarantees in life, including neuroendocrine tumor recurrences. Um, Sometimes it's worth having a conversation, like have an open conversation with your oncologist and say, I'm really worried about this. What are your thoughts? How can we mitigate this a little bit? I would say some of the things that we've done in the past is relax the number of scans. So instead of doing annual scans, maybe something like every 2 years or 18 months. Now in the US, there's also the issue of getting insurance approval. Sometimes past 10 years can be challenging. So it's a little bit hard, but it is doable. We have done it in individual circumstances, but our overall practice is to actually kind of stop surveillance after 10 years just based on what the guidelines tell us. But there are individual situations where you can make a case that maybe it makes sense to do it for a little bit longer than that. There's no studies or any evidence to suggest you need scans lifelong. And I would also say, there are certain risks of cumulative radiation with CT abdomens, as you would know, and MRI less so. So you want to balance the risks and the benefits. But individual cases, yeah, you can make the case that depending on risks for recurrence, we have occasionally done for more than 10 years. But I would say again, it's quite rare that we would recommend that.
Got it. Thank you. Kind of a big question from just lost the name from Brenda. Can a NET patient ever be NED, no evidence of disease, or is that actually temporary?
I think you mean like after surgical resection, and
Most likely, yeah.
no, absolutely. I mean, we expect fully that after your surgery, after you're done with your surveillance imaging, and if it's been between 10 years or more, the chance of recurrence is fairly limited. It's small. It's maybe 10% or less. So yeah, this is absolutely a curable disease with NED and hopefully long-term cures, as we know. But we just have to make sure that we're being conscientious about imaging to make sure that if there's anything that pops up, that we catch it. So that's why, unfortunately, we don't let you be after your surgery. We still have to do surveillance imaging. But absolutely, NED means no evidence of disease, and from everything we know, if you've been in NED for 10 years or more, your risk of ever having to deal with it ever again is really small. So that's the good news at that point.
Absolutely. Thanks, Brenda. Um, Shout out to our attendees from YouTube. We are now broadcasting there this year and usually get about 10% of our audience from there. And Dennis says, can a person with normal liver enzymes and multiple embolizations, 3 in fact, continue more embolizations? So the real question is, how safe to the liver is it to continue embolizations?
Yeah. Occasionally, I would say 3 or 4 is probably the most that I have experience with. That being said, theoretically, there really isn't a real limit. But I would say it's just about, is it helping or not? So we talked earlier about the efficacy of embolization. It's a very effective treatment. In fact, it's as effective as anything that we have. But it usually can stop the tumors from growing or coming back for 2 to 3 years in our experience. But if you're starting to notice that the tumors are really progressing really quickly, like let's say within a year or less, or around that time frame, at that point I wouldn't advise more embolizations. These tumors unfortunately figure out a way to get their blood supply from other sources, and they become much more efficient with time at doing that. So there will come a point where unfortunately doing more embolizations may not make sense. You'd rather try other therapies, but it's not that like there's a theoretical limit. It's just about how well it's working for an individual at any point.
Got it. Thank you. And thanks, Dennis, for your question. Appreciate you joining us. From Stephanie, I did lanreotide and octreotide injections for 1 year. Tumor still grew and more arose.
Mhm.
Did right and then left bland embolizations. They worked. However, more tumors are growing.
Mhm.
Would everolimus be the next suggested treatment, since now it has spears to my L1 and spine, and periportal lymph nodes?
Okay. Yeah, so it really depends on how much tumor there is, if you're getting any symptoms from it. So I always, first thing you need to figure out with your doctor is, do we need to do anything right away or not? So that's really important because, as we know, we have good therapy options, but it's sometimes smart for us to keep your options in your back pocket for the future. So I think the first question is, do we need to do anything at all or not? A lot of the times the answer may be not necessarily not today, because we know that in some folks it can be fairly slow growing, even if you're finding a new spot here or there. Um, the areas in the bones, I advise folks. The good news is it's highly unusual and almost, I would say, not very common for the disease in the bones to really determine your prognosis. In my experience, it's really like the tumors and important organs, the liver being the most important organ that ultimately I think determines overall prognosis. So unless these spots in the bones are causing you trouble in any way, I don't make treatment decisions just based on one or two spots in the bones. Okay. Um, but there may be a need to start something if we're starting to find large bulky spots, important organs causing you issues. At that point, it's worth talking about what the next best options are. I think usually the approved treatments are both everolimus and PRRT. I'm assuming this is a small bowel carcinoid, but if it is not, then there's Captem and Sutent as well, sunitinib. So the first question is, do we need to do anything right now?
Mhm.
And if the answer is yes, then you do have other options, which I mentioned. No one really knows one versus the other. Sequencing again, I think it's really up to clinical experience and comfort and where you are in terms of your disease prognosis and side effect profile, quality of life, what your goals are. It's a little bit different for each of the agents that I mentioned, but all of them are effective approved therapies.
Got it. Question from Dennis: how many series of PRRT can a person have, and are there different PRRTs other than Lutathera that are currently approved?
So the FDA label is for 4 doses of PRT Lutathera. I will say that there is a study that is it's called the Retreat study that we are in the process of opening up, where patients who've already received PRT will be treated with more doses. So we know from experience from Europe specifically that more than 4 seems to be fairly efficacious and safe. They have done, I think, even up to 8 in some situations. So we don't necessarily have experience in the US at our center, at least. We have stuck to the label fairly religiously. So we are really looking forward to opening the study. We will be one of the champion sites for retreatment with PRT. So we should have more, I would say, robust data in the next few years. In terms of other agents, absolutely. So I think everyone here is aware of some of the alpha therapies that are coming up. So I won't dwell too much on that. But so we are having newer agents like lead actinium, which emit different types of radiation with different efficacy. We think more efficacy. But as of today, it's really early trials. So yeah, there's a lot to be learned, and we are doing certain important studies in the next few years, which will answer some of these questions.
Got it. Speaking of alpha, we just had a question from Jim that came in that was simply, are there any updates for the alpha PRRT treatment?
So there's a couple of different agents that we are both opening up at our site. We should be open, hopefully in the next few months or so. It is because of the fact that these are fairly new therapies. Our institutional review boards are quite exacting in their demands. They want to make sure they have all the data available to ensure that these treatments are safe and effective. So that's some of the delays I would say are based on this being an abundance of caution. So we should have. We're hoping to have these agents open and available in the next few months, but not yet at our site. Each of them have a little bit of nuances. So the lead agent, they do also have an openings for patients with pheochromocytomas and paragangliomas who I treat here at Ohio State. So that's a unique population of neuroendocrine tumors. So we will have fewer, newer agents coming up fairly soon, which we're really excited about. The initial data looks promising, but until we have they're officially open and until we have a few patients on the studies, I wouldn't have too much to update here until we pass that milestone.
Got it. And a second part to that question, are there any studies with NET and new cancer drugs like dostarlimab or AOH 1996?
Hmm.
I'm unfamiliar.
I'm not familiar with the AOH drug. I apologize, but dostarlimab, it's an immunotherapy. So that's a good question. So I would just talk to you very briefly about some of the work that we have done in the immunotherapy space.
Please,
So
yeah.
one of the studies that we're very proud of is a combination of temozolomide with immunotherapy in neuroendocrine tumors. We did that as a single center study of 30 patients with neuroendocrine tumors. So what we found was that, and I think some of you may be aware, so unfortunately, the slow growing, well differentiated neuroendocrine tumors don't respond very well to immunotherapy. Um, and dostarlimab is a type of, it's an anti-PD-1, PD-L1 agent, which is an immunotherapy agent. It's approved for certain gynecological cancers, if I'm not mistaken. So the question is, why is it that our neuroendocrine tumors, the slow-growing, the grade ones and grade twos, well-differentiated, why is it that they don't, seem to respond? And there's multiple theories about that. One of them is that slow-growing tumors don't have the same number of mutations which the immune system recognizes and attacks. So that may be one of the reasons. There may be also strong suppressive mechanisms that these tumors are using to prevent the immune system from attacking them. So what we found was that in tumors where temozolomide is already approved, like pancreatic neuroendocrine tumors or foregut tumors, we call them, and lung tumors, neuroendocrine tumors, the combination seemed to have a fair amount of efficacy, even more than individual single agents. So combining them seems to actually work better than single agent use. So we find that to be very promising. And our study, the one that got published earlier this year, was fairly small. It was a single center. But what we are doing now is we are approaching larger cooperative groups and other mechanisms to do some of these studies in a bigger fashion, in a randomized study, at least in the beginning, to see can we really prove that these agents work better together than individually. So that's really the focus of some of a big thrust of what I've been doing at Ohio State has been moving that work forward to try and understand what are the mechanisms for resistance, and b can we really take these combinations to the next level and hopefully get bigger studies out there that'll move the field a bit forward. So dostarlimab is an immunotherapy agent. I think it would be similar to some of the others. There's three or four at this point, maybe four or five. So specifically, there's been no studies with that agent, but there has been studies with Keytruda, Opdivo, a few of the other agents. And the bottom line seems to be, for the slow-growing tumors by themselves, they don't seem to do much. But for grade threes and above, or the carcinomas, the poorly differentiated ones, they do have a role to play. And some of our emerging data seems to suggest that combining it with other agents does seem to make sense. So that's a brief summary of what we've been working on.
No, I appreciate that so much, and I think that's the perfect place to end today's show. I'm very appreciative and grateful for the work that you and your team are doing in the field. I'm sure that the attendees are today too. I'm also very appreciative and grateful for you spending time with us today. Thank you so much.
Thank you to everyone for all your questions. I really appreciate it. And I'm sorry if we weren't able to answer your particular one, but I hope I can connect with you guys again in the future.
Absolutely. We hope to have you back on the show. And thanks again to you all at home. As always, we hope this program helped answer some of your questions. A reminder, please reach out to carcinoid.org or lacnets.org/support line if you have any other information or for seeking other information or if you have any other questions. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.